Good morning. I'll be speaking on evidence-based management in microbial keratitis. So, for me, from my point of view, the evidence starts with a good history taking. It starts with the age of the patient, as older age is prone for fungal and viral infection, and younger age has more uses of contact lens and are more prone for bacterial infections. The location, the place where this patient is staying, also takes part in the evidence, and the duration of symptoms. That is, the fungal and acanthamoebal infections are longer, and bacterial infections are of shorter duration of symptoms. The mode of injury, that is the vegetative matter, plays part in fungal infections. Ask for any steroid intake and ask for any previous history of similar episodes in case of viral keratitis. Next, moving on to systemic history, ask for the history of diabetes, herpes, HIV, TB, respiratory illness, which may all point out to immunocompromised state. Ask for history of acne rosacea, as it can cause immune-mediated keratitis, and ask for history of drug intake, which can point out to many underlying illness and steroid intake. So, when you ask the patient if they are diabetic or anything, they tell no. But when you ask for the medication, they show all the anti-hypoglycemic medications and everything. So it's always better to ask for a drug intake history. Next, for lifestyle based questions, ask if the patient is contact lens wearer, as Pseudomonas the most common ulcer cause in contact lens wearers, and acanthamoeba is most common in contact lens wearer, but it is not the most common ulcer in contact lens wearers. And in occupation, ask for a history of any healthcare professionals, as mycobacterium infections are more common. And then ask for history of swimming, agriculture, and ask for hospitalization due for immunosuppressed state and candida infections. And in clinical examination, it's always important to examine the visual acuity and correlate with your ulcer, and check for corneal sensation. In slit lamp examination, do a detailed examination about the location, surface, depth, the margins, and the AC reaction. Always avoid the lid and look for foreign body. Look for patency of nasolacrimal duct, and do a fundus examination where possible, or do a B scan. In case the visual acuity is not correlating with the degree of ulcer, always do a B scan and look for posterior segment pathology. In investigations, do a culture sensitivity with staining, a PCR, and immunoglobulin markers. And once you with the staining, you get to know whether it's a bacterial or fungal infection. Start with empirical treatment. In case of bacterial ulcers, start with topical broad spectrum fluoroquinolones like moxifloxacin or gatifloxacin. The starting will be 30 to 60 minutes every for 6 hours, and then re-evaluate the patient after 6 hours and taper the dose accordingly, or change over to another antibiotic. And in very severe disease, even a 5-minute dosage is preferable. So when you get gram-positive cocci in staining, you can start the patient on 45 reconstituted cephalosporin eye drops, vancomycin, moxifloxacin, gatifloxacin, levofloxacin, or becifloxacin. In case of gram-negative rods, which are most commonly Pseudomonas, you can start the patient on tobramycin 0.3%, which is available as prepaid formula, or you can fortify it with the injection, which is 1.4%. Ceftazidime eye drops, ciprofloxacin, ofloxacin eye drops, moxifloxacin eye drops, gatifloxacin, levofloxacin, or becifloxacin. In case of gram-negative cocci, you can start the patient on ceftriaxone eye drops, ceftazidime eye drops, ciprofloxacin, moxi, gatifloxacin, levo, or becifloxacin. In case of Mycobacterium keratitis, start the patient on clarithromycin 10 mg per ml, amikacin 20 to 40 mg, which is more widely available, moxifloxacin or gatifloxacin or becifloxacin works as well. In case you get no organisms or multiple organisms, you can start the patient on 4th generation fluoroquinolones or fortified cefazolin, which works on gram-positive, and along with fortified tobramycin, which acts on gram-negative organisms. This is a table taken from AAO, which shows the different antibiotics and the dosage and subconjunctival dosage for different things. And this is how to prepare the reconstituted drops for cefazolin, vancomycin, ceftazidime, and tobramycin drops. And when the KOH mount shows fungal ulcers, start the empirical treatment with natamycin eye drops 5%. In case of filamentous fungus, especially fusarium, natamycin is found to work better than voriconazole, and in yeast keratitis, amphotericin B works better. An intrastromal injection can be tried for deep stromal or intracameral injection, and amphotericin B or voriconazole can be used. When things go awry and it doesn't respond as you expect it to, always go back and look for immunocompromised state, and then again look at the suspect list. And when all else fails, look for PCR for viral markers, a confocal microscopy, or a biopsy. So these are a few examples. A 26-year-old female with uncorrected visual acuity of 3/60 underwent uneventful trans-PRK. Post-op vision 1 month was 6/6. Went back to work at Regional Cancer Institute after 1 month, and 2 weeks later called back telling she has an irritation. We were asked to consult locally, and there she was diagnosed as having corneal ulcer. And when she came back with this picture. So on scraping, patient was found to have acid-fast bacilli, and culture grew this atypical mycobacterium. Patient was started on amikacin eye drops and gatifloxacin eye drops. Once the symptoms got better, she decided to go back against medical advice, and there after 3 days she developed severe pain. When she consulted again there, she was diagnosed to have fungal infections superadded and was advised therapeutic keratoplasty. And COVID hit, and the whole world went into lockdown, and the patient decided to come back to her hometown. And these are the pictures which after she started healing actually, and she was hospitalized for 78 days with us during the lockdown. And once the infection started healing, we were started the patient on steroids, and later the vision improved to 6/12 uncorrected. So she's pretty happy with her vision, but still she has some scar. This is another patient, a 47-year-old male, an absolute eye with a neovascular glaucoma, who was referred as perforated corneal ulcer. But on examination, we found it to be a pigmented corneal ulcer. On culture, it was Aspergillus nigrans and started on amphotericin eye drops. It healed with a depressed scar, but the depression still persists, but the patient doesn't complain. This is a case for another 42-year-old male who presented with a white spot in the eye. He had no other complaints, no pain, absolutely normal. Clinically, it was found to be like a cystic lesion, so treated for parasitic cyst, but it kept progressing, and we thought that a lens was involved. So we went ahead with the AC wash. On culture, the Aspergillus species was found, and so post wash, we gave an intrastromal amphoby and intracameral amphoby along with oral antifungal, and the ulcer healed with the scarring. So 10 commandments will be a proper history taking, proper evaluation of systemic illness, visual acuity, whether it is correlating with the disease, blood sugar, the duct examination, clinical examination, a corneal scraping with the proper culture, empirical treatment based on staining initially, and then convert over according to your culture results, and follow up the patients closely. Thank you.